Thanks for that introduction. I'm just going to go ahead and start, moving ahead because we only have an hour and this is a lot of content to cover. So just for some background, my area of research focuses on research literacy and capacity building. We've developed instruction to make the scientific method more accessible to people that are not scientists. So originally it was community health workers that were liaisons between academic researchers in public health and communities locally in San Diego where health disparities are most prevalent. And so we've been working with community health workers, mostly monolingual Spanish speakers, teaching them about the scientific method and what their role is in advocating for their communities, and also in how to be involved in the research process. So we're taking that curriculum now and migrating it to for use among the citizen science community. And the undercurrent of my talk is really about how digital technologies are being used across all sectors to, in some cases, to democratize the research process. And as that process is happening, there are a lot of things that are unregulated, and those are areas that I'll be touching on today. And the other area is this health tech ethics. So about 6 or 7 years ago, some of my colleagues in behavioral medicine wanted to use different kinds of technologies to understand how people behave in their natural environment. So they call it basically, how do people act in the wild? And I'll be talking about some of the tools that they were using and some of the challenges that they had getting ethics approval to move those studies forward. This is where I work, which is the building right next door. I've been there for about the past 5 years. Prior to that, I was at San Diego State University. I was there for probably close to 15 years. And that's where I started to do the research on research ethics that I've been doing for the past 20 years. And that's led us to creating a center that was recently funded by UC San Diego that's called the Research Center for Optimal Digital Ethics. And this was really something that we had been working toward, but the Cambridge Analytica fiasco really propelled us in this direction because we had been working on the problems associated with what then became the Cambridge Analytica problem for 5 years before that ever happened. And this is a group of the people that I work with, so I really want to acknowledge the team that we have that has just been incredible in helping us move all of the things forward that we've been doing. And just for some context, a lot of the research that we've been doing on human health has been really focused on the human genome. And for so many years, I'm going to say close to the past 30 years, the health community really thought a lot of our health issues could be solved by better understanding the human genome. More recently, as the Precision Medicine Initiative and the All of Us research program have gotten launched, there's been a lot more focus on not health behaviors and environment as things that can help explain the human genome, but as really important aspects of human health across the board. So as you'll see in this slide, 30% of our health is attributed to genetics, whereas 70% is our lifestyle and our environment. And so we're really looking more closely at how lifestyle and environment influence our health. And because of digital technologies, we have so many new ways of doing that. So how many of you would have thought that you could identify HIV hotspots by analyzing publicly available tweets? Right? So one of my colleagues has gotten tweets that are geotagged for San Diego County and has been able to analyze those tweets to identify who is communicating about HIV behaviors, and then has taught done machine learning through computer science to do predictive analytics on where geographically HIV is likely to happen in San Diego County, and that's all through publicly available tweets. Now, when you think about traditional academic research, Twitter didn't exist when we came up with the regulations and the guidelines to guide ethical practices. So tweets are public. They're not even considered human subjects research data. So if you're talking about things that are really sensitive and you have set your Twitter status to public, anybody can have access to it and they don't need to ask your permission. But do the people who have Twitter accounts really recognize what it means to set their settings to public? So I mean, it's opening up some new questions that we've really never had to think about before. And also with respect to Twitter, when my colleague went to publish that paper in the academic literature, as qualitative researchers do, they used quotes directly from the tweet to demonstrate how this behavior was being interpreted. Now, you can take that tweet out of the academic literature, stick it into Google, and identify who that person is. So these kind of new ethical challenges around privacy, data management, informed consent, they're all new for how we're thinking about moving this field forward. So when my colleagues started to do research trying to figure out how do we use different kinds of technologies to better understand how people behave in the wild, they wanted to use a wearable camera. This was before Fitbit existed. So they wanted to use different kinds of wearable GPS devices and accelerometers to see what people were doing in their everyday life. Now, this is one of the devices that they used, and it's a camera that hangs around your neck. They recruited people from Craigslist, so 200 healthy individuals were asked to come to the lab, pick up the gear, wear it for a week, and then return it back to the lab. Now, how many of you, if I were in that study, say I volunteered, how many of you would have wanted to consent before I started talking and in what might be considered a public venue? Anybody? Because you're the people that would be in my data set. This would be taking pictures of what's in my sight line, and that then becomes part of the data that the researchers are using to figure out what do I do in my everyday life. That's what the IRB, for those, how many of you in here know what an IRB is? Institutional Review Board. It's a required body that every institution has to have if they accept funding from the federal government. And that's the body that will review research in advance to make sure that it's compliant with regulations for human research protections. So in this setting, if I'm the person that has agreed to be in the study and I've agreed to wear all of these different devices, I'm the human subject. So I can consent to do that. But there is nothing in the research question that's about you. You're going to be in the data set, but we're not going to answer any research questions about you, so that means that you're not a research subject. But should you have the ability to consent when your image is being captured and under what circumstances? Now, if I'm wearing that camera and I go to my family's home and I'm still in the study, I've been asked to wear that camera, should I disclose it to you? Should I take it off? So these are all of the kinds of new questions that are coming up as we start looking at these different kinds of technologies. And this is an acronym that our team created just to try to get a better sense of what kinds of tools and strategies were being used. And so I've mentioned, mobile apps, wearable cameras, pervasive sensing, which would be a Fitbit or an Apple Watch, social media, and location tracking. And so the tools being used to capture personal data today are pervasive and ubiquitous, and it's producing data that we've never seen before in this level of granularity and volume. And so now, whereas 30 years ago we couldn't do this, now we can watch people, we can intervene in real time 24/7. We can know everything at a granular level. We cannot promise data anonymity anymore, so if anyone tells you that your data is going to be anonymous, don't buy that. And what's really been interesting in the past 5 or 6 years I've been doing this is that the people or the organizations that were the tool makers, like Microsoft made this camera. They made it because people with dementia wanted help in remembering their day. So they created a camera to help people remember what they weren't able to remember on their own. But they weren't doing the research. They were creating the tools that researchers would use or clinicians could use. But now, the big tech companies like Google has Verily, Microsoft Research, IBM Research. These big companies are now doing biomedical research, and it's introduced some really interesting issues because they're not regulated like those of us that are with an academic research institution. Completely different, and in some cases, no regulation. So the mobile methods that I was mentioning to you are used in studies. For example, I might get pinged if I'm in a study that's doing ecological momentary assessment, and what it'll do is it's going to push a survey to my phone to find out really quick questions. Have you exercised today? What's your mood? They might show me 9 pictures of a pony, a lion, and I pick my mood based on that. Or it could be a really quick cognitive test. But anyway, I do that really quickly on my phone. That's called ecological momentary assessment. It gets pushed back to the researchers. It may go through a third party. It may not. So there's new considerations with the different kinds of partners that researchers may have. This is the example of the wearable camera. Those are 3 different versions. The one in the middle is the one that I just showed you here. What's interesting is that when I've worn these in meetings or just for fun, people think it's either I have really bad taste in jewelry, or they think it's a medical device and they don't want to ask me about it. And so even though they notice it, they don't know what to say about it. And so I thought but they're also all black. What's happened with the SenseCam, which is the one on the right, no, that's the autographer. They've made it now in a really ugly green, so you cannot miss it. That was something that I noticed when I was in Australia last year. This is a wearable sensor that was made by Todd Coleman, who's over in bioinformatics right across the grass there. So this sensor is about the size of a postage stamp, and it can be worn on the skin. It captures temperature, EEG. It can transmit your physiological data, sweat information. It can transmit that wirelessly. He was using it originally to see whether or not he could capture fetal heart rate and maternal contractions so that they could communicate with a woman who was about to give birth and kind of coordinate when that person actually needed to go to the hospital. All of that was being done remotely. These are just some examples of the social media methods that are being used in academic research now, trying to better understand how we can push interventions out on Facebook. Studies are now recruiting on Facebook, deploying studies in Facebook groups. And all of these commercial products came out within the past 5 or 6 years. And what's been interesting is as studies, academic research studies that are regulated have adopted these types of technologies for research purposes, there's an absolute conflict in our federal regulations for human research protections and the terms of service that these companies have created to protect their business. And so the NIH has invested $300 million in the All of Us research program. They have a deal with Fitbit to deploy 10,000 Fitbits in that All of Us research program. And the All of Us research program is an NIH-funded study that is being directed by the National Institutes of Health. And they couldn't use Fitbit because it conflicted with the federal regulations for human research protection. So the federal regulations state that if you're harmed in a study as a result of being some tool that's involved in the study, you can sue the researcher, you can sue the institution. But Fitbit says absolutely not. You have to agree to arbitration. You can't sue us. We're completely bulletproof. They recently, just like 2 months ago, created a research-friendly terms of use so that they started working with the language a little bit, but only for researchers. And I'm pretty sure it was only so that they could partner with the All of Us research program. And then they got bought by Google. So then what happens? So are these terms and conditions still the same, or do they change? So these are just some of the new methods and the types of data that are being produced. You can see if somebody's wearing the SenseCam, you can look at what they're eating. Now, prior to the SenseCam being in existence, the only way we had to ask people about what they ate was to ask them what they ate. And then we have to trust that they not only will tell us the truth, but they can estimate how much they were eating. And so this salad could have been, I'm eating a small salad, or it could have been that they were eating a chimichanga with a lot of beans, but this is what they're telling the researchers. I just had a small salad and a small piece of fish, so you had to rely on self-report, which isn't very accurate. You can see with the GPS device that that's tracking a person. The data is right underneath. In California, it shows that that person is actually going back and forth across the border. If there's some kind of a crime or something that needs to be accessed and you have the GPS coordinates of that person for every single minute of their day, and that's discoverable in potentially some kind of a lawsuit, do you have to give that up? Could that really, in fact, point somebody to being at a crime? Or if I'm in a study and I go to a bar after work and I have a drink and then I'm texting and driving and I hit somebody and all of that's now recorded, is that a different kind of risk that we need to think about? So anyway, those are just some of the types of data. This is a study that was done at Dartmouth University. And about 5 years ago, there was a lot of publicity about college student suicide. And so Dartmouth wanted to look at the pattern of the flow of a quarter at Dartmouth University. So a computer science professor asked 40 students in his class to download an app onto their phone that would keep track of their activity, their conversations, their sleep, their location. They deployed surveys through ecological momentary assessment on their phone. They had them complete surveys about their mental health using SurveyMonkey links. So you didn't have to actually ever interact with that person. Everything was being captured on their phone. And then they put it all into the Student Life Cloud, and they looked at the mental health, academic performance, behavioral trends, and just the entire scope. So they didn't have to look to see if somebody showed up for class because they already knew what class they were supposed to be in and could tell from their GPS coordinates whether or not they showed up, because all of the sensor data was tracking that person. What was interesting about this study, and I think it's really an important study to look at college-age suicide, and these students, could they really volunteer if it was their faculty member, their professor asking them to be in a study? So there was a little bit of a worry about coercion. The IRB approved it at Dartmouth, but it made me wonder whether or not the IRB really knew the nature of the data that were being collected. If they really understood it, would it have been acceptable? Could those students truly choose to opt out? What was and another interesting part of this is that the faculty member really was an advocate for open science, wanted to share data, wanted other people to have access to all of the data so that they could answer other questions. And 2 years after the study ended, they posted the entire data set on the website. Now, you can take that data set and you can identify who people are because you have their GPS data. You can tell who's sleeping in the same place every night and figure out who lived there. So it's just curious to me that that was thought to be a good thing to do. And this kind of is really what got us started here. You know, as I mentioned, my colleague wanted to use these different devices. This is a research assistant in the lab wearing a GPS, a camera, several accelerometers, and the IRB said no. And she had 4 NIH grants ready to start. So she had asked me, can you help us? And I said, you know, the IRB has no idea what these devices can do, what kind of data are being produced. So maybe what we should do is start doing research on the research so that we can figure out whether or not it's risky, the extent to which people think it's risky. And so we started to think about how can we convene the people in the ecosystem to start answering these questions instead of outsourcing ethics to an IRB that may or may not be prepared. And so that's what we started to do. We ended up getting funding from the Robert Wood Johnson Foundation, and that launched the beginning of this study, where we started to think about how can we crowdsource ethics in the digital age. And Nadir Wiebel is my co-investigator over here, and we've over the years have just been doing quite a bit of research. We looked at IRB determination letters to figure out what kind of risks they thought were going on. So we didn't have to go to the IRB to ask for that. The principal investigators gave us all of their IRB communications, and we analyzed that. What we found was that the IRBs were missing things, they were inconsistent, and it was, we figured if it was happening here locally, and we have 6 IRBs locally, if the IRBs at one institution can't figure out what the risks are and are inconsistent, you just think about multiplying that out to 6,000 IRBs across the US, and you just get a big mess. And so we also wanted to find out from IRBs what would be helpful to them. Do they want help? What would that look like? And they were worried about being inconsistent. They were worried that they didn't know what they didn't know. And they didn't think that they had adequate expertise within their own institution to be consistent. We also wanted to find out what participants thought. So the people that were recruited from Craigslist, we asked them after they participated in the study, what did you think about wearing all of these devices? Did you worry about privacy? Was there anything that surprised you? Most of the people had forgotten that there was a privacy button on this, and so they never thought to push it, but they would stick it inside their shirt if they thought they were in a situation where they probably shouldn't record it. They also forgot to turn it off when they were in situations where they probably shouldn't have worn it, like in their home and bathroom and things like that. But what was interesting about when we asked them about their preferences for privacy, they rated themselves as incredibly private people. And yet they're wearing a camera that's taking pictures of everything that they do in their everyday life. So if you've ever heard of the privacy paradox, I think that's really truthful. We also looked in our community. In San Diego, we have a really diverse ethnic composition. We're probably close to 40% Latino. We have a growing Native Hawaiian Pacific Islander community, a very large refugee community, and so we did research with those communities to find out what they thought about using devices like this. Would they be willing to? What would they be worried about? And the Latina women that we interviewed were really concerned about potentially picking up information about somebody that they might be transporting that wasn't documented. And maybe because they were wearing different kinds of tracking information, it could put somebody else at risk. The refugee women didn't want to wear anything on their wrist because of their daily prayer habits. They said if we wore something, we'd want it to be a clip-on or something else. So doing that kind of formative research is really important if you want people to pick up the kinds of tools that you're using in research. We also looked at terms and conditions of service. How many of you in here read those? I see no hands. Well, they're not meant to be read, so that's good on you because they're not intended for you to read them, but they're not readable. So we looked at terms and conditions of service that were applied to tools and devices that were targeting adolescents, and they were all rated at a much higher reading level than an adolescent can read at. So they weren't accessible. And then we looked at the NIH and what NIH is funding to see whether or not this is just a speck of, something that's just a novelty or whether it's starting to pick up. And we found at 2005, 2010, and 2015, over those 3 time points, the funding for this had increased 368%, and it still only represented about 2% of the NIH budget for this, but it was definitely growing. And what we figured out through all of this research, and there's more that we've done that I didn't list there, is that we really need to start thinking about how do we build capacity, not only for IRBs, but for participants, consumers, for researchers who are doing this work, for the engineers that are making the tools? How do we work together so that we can really think about collectively what we should be thinking about in terms of accessibility, effectiveness, safety, security, data management, and flows? And informed consent is not even informed now, but it's getting worse because we have a tech illiterate, data illiterate, and research illiterate population that we're working with. And so while we take the consent templates that our universities say, you know, get that 18-page thing, go get it signed and you're good, that's not informed consent. That's compliance with what a university wants you to do to make sure that they're covering that. Bystander rights. We have no guidance on how to work with bystanders who are picked up in the data set. Risk assessment is subjective, and data management, we don't have standards for sharing, security. There's just a lot of messiness in our ecosystem right now. And we study the ethical, legal, and social implications of technology that's being used in health research. And so, as I just mentioned, we have literacy issues that affect the risk assessment, the consent, and access to diverse populations. Our legal and regulatory domain only covers certain groups, like academic researchers who take money from the federal government have to follow certain rules, whereas other organizations don't. And so that's creating, obviously, how many of you in here heard about Google and the Ascension merge? So a major healthcare system has entered into an agreement with Google to share all patient records, and it already has happened. And people are saying, well, you know, they did everything that was compliant, they followed HIPAA, it's all good to go. But the people haven't consented to that. The patients, nor their physicians, should they have. These two organizations are not covered by the federal regulations for human research protection, so they don't have to do what we would have to do in order to move that kind of research forward. So there are no protections and there are no guardrails at this point in time. So we've been publishing our research on this and getting information out into the peer-reviewed journals, but there's also things beyond academic research that we should be paying attention to as consumers. So increasingly on the app stores, and this is a really interesting line of distinction, you have digital health and wellness, and then you have digital medicine. And so digital medicine is when you're creating a product that you want to have deployed in the medical system. The health and wellness are making claims that they can do things that will help you, but they don't have to have FDA vetting. So they're like under this radar of no one's paying attention here. So you can see this Headspace app. It's used for meditation. It's one of the most frequently downloaded apps on the market today. And in their disclaimer, they say they're in the health and wellness space. They're not a healthcare or medical device, and their products are not to be considered medical advice. If you have a medical concern, go to your physician. And then they talk about, while there's third-party evidence from research that meditation can assist in the prevention and recovery process for conditions, as well as in improving some performance and relationship issue, they make no claim that this product provides a therapeutic benefit. So that's something to pay attention to, and this is something, I was interviewed for this article last year. Your computer may know you have Parkinson's, should it tell you? And this is all based on your keystrokes and the patterns in your keystrokes. And so they have been able to do some predictive analytics using your keystrokes. How many of you have heard of Coursera? So the thing that was so fascinating about Coursera, not only are they making education available worldwide, but the way they authenticate that you're the person that's getting certified for taking that course is your keystrokes. So everyone has a unique keystroke signature, and that was their brilliance, is that's what they were able to have as their intellectual property. So they can authenticate whoever wants to get that course for credit just based on your keystrokes. But now the keystrokes are being used as a diagnostic. Now there's a company that is in California. It's called MindStrong. And it has just been contracted by the state mental health for $66 million to start deploying its app on the people who use the California's public health mental health system. And they have one article that's been published in the literature with 24 people. And that's the evidence. So with this Google Ascension program with MindStrong, the consumers become the data source that they are now using to test the algorithms that have not been proven to be effective yet. That can happen because there is a lack of guidelines, lack of regulations. Some people don't know that the regulations are lacking, and they just are kind of plodding through this new terrain. And some people know very well that there are no regulations, and they're exploiting it like crazy. So here's another. Facebook is now has an algorithm that is flagging suicidality. And based on what you're writing in Facebook, they can identify whether or not they think you're at risk and deploy either some type of healthcare support or some type of emergency response to your home. Without asking you if that's what you would like, they're just starting to do it based on what you're typing. And this one came out in the Washington Post just a couple months ago, where the government here is planning to, they originally wanted to do this to solve the disease of pancreatic cancer. The CEO of GE's wife died of pancreatic cancer. He said there's no reason why we should still have pancreatic cancer. If we could just get contracts in the right hands, we could solve that problem. And then in the summertime, when we had these mass shootings, they decided, well, instead of focusing on pancreatic cancer, let's use all of these wearable sensors that everyone's using, and we can figure out who has a mental illness, and then we can stop mass murders. And there's no evidence to show that any of that is connected. The scarier part is that Ivanka Trump is the person that they would identify as the director of HARPA.
Hopefully that means they'll collect data.
So another example of just GPS data is just, this was in the Times, showing that this person was recorded going all over her community every like 8,600 times on average. This occurred when I was giving my talk in DC, that Google was paying people $5 because they recognized that their facial recognition didn't have enough color in it, so they were paying people that were darker skinned $5 to see if they could take their picture so that they could improve their analytics. This one I've just been watching because it's so fascinating. Netflix has this program called Unnatural Selection on, where they're teaching people how to get CRISPR off the internet and do experiments on themselves. So this is a
recent biohacker died.
Yes, yeah, right. And there's no rules. That's what I mean. Is that this is kind of like open. And some people are doing it incredibly responsibly and really trying to think through all the steps to make science accessible, make citizens part of the process. And then there are those that are just perpetuating potentially really dangerous activities. And so some of these companies are really good companies. They're trying to do the right thing. They're trying to be socially responsible. A lot of folks who create the companies are people who have had a personal experience. Parents, grandparents have had Alzheimer's. They now want to cure Alzheimer's, so they create a product, they deploy it. And sometimes that's where they start collecting their data. So I think that, if you haven't seen the Theranos book or movie, take a look at it. But the behavioral sciences are going to have their version of Theranos if we don't start thinking carefully about how to move this forward. This is basically from the last 24 hours where Google is mining personal health data, and legitimately, because they have now passed all the HIPAA rules, except the Office of Civil Rights is really looking into this to see whether or not they actually did adhere to all the HIPAA rights. And this is just basically a diagram where what I'm saying, and this is probably a bad way to do it, but we have citizen science involved, people that are doing what we call participant-led research, do-it-yourself, group self-studies. Because these tools allow people to keep track of their own health behaviors, people are starting to learn about themselves and learning about what they can do to change their health quality. And sometimes they want to know, how do I do that in a way that's going to produce meaningful results? They want to learn how to do it systematically so that they can get good data and learn about themselves. But then on the other hand, there are people that are doing things that could be reckless. But they may not have the scientific training, they may not have been acculturated in ethical practices, and they may have no regulatory structures to help guide. That's kind of the lower left. And then we have people that are working with academic scientists, or who I would call professional scientists. They're community health workers, they're crowdsourced science workers, they're potentially not-for-profit, that are partners. And so there's a little bit more training and a little bit more potential to have the right combination of training, ethics, and regulation. And as I mentioned, the bio and tech industries are getting much more involved, and there's just got to be some awareness that there is a lot of variability in this domain. And then I'm working on an IBM-supported study about artificial intelligence, and how do we create technologies that will help people age in place. And so what kind of technologies will help support somebody that is living in an assisted living facility or has powered their home as a smart home? And so this is just an example that your home can be censored so that you are automatically programmed to know if the person is drinking enough fluid. The caretaker gets information. There are different kinds of ways of reminding people to drink water. If there's nothing going on right, then an alarm goes off. So these are things that could be very, very helpful for helping people age independently. What we're doing is coming up with checklists to help people who are designing the tools or deploying the research think through what they need to think about when they're designing the studies. And I don't expect you to read that, but I just want to basically say these are the areas that we're focusing on, which are the core principles of biomedical research ethics. We're changing what consent looks like. We're taking what is this ugly, text on paper that's a lot of words that people aren't familiar with. And we went to the retirement community and we said, what would consent look like if it was designed for you? And they have helped us create a prototype that we're going to now deploy on the American Gut Project's website. And this is designed to give people the information they need to make informed choices in a way that is accessible. So this is all based on what people told us they wanted. Older folks that were trying to read the 12-point font that was approved by the IRB said, we can't read that. Our eyes don't work that well even with glasses, so if we could have a little scrolling bar that made the font bigger, that would be great. And we don't know where everything is in this big document, so can you tell us just what the headings are so we can click on that information and just get what we want about that? They also wanted to be able to see a procedure videotape so that they could actually see what they were going to be doing rather than just try to read it. And so now some of the work we're doing is to take information back to community members so that we can share what we're learning with them. We're taking peer-reviewed papers and putting them into infographics that are visually appealing. We're actually doing a focus group with residents at the retirement community tomorrow to say, is this getting close? Are we actually, is this a way that you'd like us to communicate with you? Because in order to keep people engaged in studies over time, we have to do something that is a give and take. We can't expect people just to keep giving data for research purposes without having some kind of a relationship. And we're asking the retired community members what they'd want in order to stay engaged over time, what would be meaningful for them. And they actually want to know about themselves. They want to know what we're learning about them as a group, which is what this is. They also want to know what are we learning about them over time, and how do they compare to other people their age. How do they compare to themselves from, a month and a half ago? So resources, this is the work that Nadir and I have done together. We created the Connected and Open Research Ethics Platform. It's a place where people are sharing their resources, resources meaning protocols and consent language. There's a forum where people can go and ask questions. You could even ask your questions anonymously so that you can actually get feedback from other people about whether the algorithm that you're developing, have you missed something? Is it potentially biased? What else should you be thinking about? These are some examples of what's in the resource library and our forum. This is a checklist that's available on our site that we have tested through an iterative process to come up with this framework that will help people across the ecosystem make decisions. And Recode Health is now the center where we house all of these things. And with that, I think I'm going to stop and see if there are questions. And there, yeah, I'll stop.